Good evening, everyone, and welcome to our Women's Health event, Understanding the Change. I'm Violetta Praga, the gym manager here at MaxFit, and I'm so glad that you can all join us here tonight, whether you're here in person or you have joined us virtually. So hello, everyone who has logged in. So tonight is about creating a safe and supportive space to learn more about perimenopause and menopause. So it's an important journey that impacts us women, but also the families, our families, friends, and communities. But a bit of housekeeping before we begin. Bathrooms are located just next to the reception area. On the table near the roller door, we have got, help yourself to water. We've got collagen drink in the jug, as well as True Protein protein bars. Later in the evening, we will be drawing a lucky door prize, which is a 10 class voucher at MaxFit. So if you haven't collected a ticket yet, please see me before the draw so you can be in it 2 minutes. If you have any questions as the night goes on, there is a QR code that's just stuck on these poles here. So if you want to scan that and send your question through, and we will come back to those questions at the end of the evening. And lastly, if we can put our phones on silent, that would be amazing. So before I begin, can I just give a massive shout out to True Protein, who have sponsored tonight. And they have not only sponsored us, but also supplied the True Protein samples at the table there. All right, so let's get started. We are very fortunate to have 3 incredible guest speakers with us tonight, each bringing their own expertise and experience. We have Dr. Monika Fazekas, Lauv, Heather Minnich, and Lara Perrett. Tracy will be introducing our first speaker, Dr. Fazekas, Lauv.
Hi everybody, for those that don't know me, I'm Tracy. I'm a trainer here at MaxFit. So Dr. Fazekas Lauv earned a Bachelor of Science with distinction in Biochemistry and Microbiology from the University of Victoria, British Columbia, Canada. She moved to Australia in 2004 to pursue medical studies and completed her Bachelor of Medicine and Bachelor of Surgery degrees at the University of Sydney. Her advanced training in endocrinology has undertaken at Prince of William and St Vincent's Hospitals. She is a Fellow of the Royal Australasian College of Physicians. Dr. Monika Fazekas Lauv is the founder of Sunrise Endocrinology, a multidisciplinary specialist practice based in Chatswood. She leads a dedicated team of 3 experienced endocrinologists and credentialed diabetes-educated dietitian and a certified lymphedema therapist. Dr. Monika has particular clinical interests in bone health, perimenopause, lymphedema, thyroid disorders, gestational diabetes, and metabolic health. Dr. Monika holds specialist accreditation at the Mater Hospital and North Shore Private Hospital. She's a member of several key professional bodies, including Endocrine Society of Australia, the International Endocrine Society, the Australian Diabetes Society, and the Australian and New Zealand Bone and Mineral Society. She is committed to staying at the forefront of her field by regularly attending national and international medical conferences. She is passionate about providing personalised, evidence-based care with a strong focus on empowering patients to achieve their health goals. Please welcome Monika.
Thank you for inviting me to speak tonight, and thank you for that introduction. Sorry. So this evening I'm going to be taking you through understanding perimenopause and menopause, and the treatments available, and help you empower yourselves. I have no conflicts of interest to declare tonight, and this presentation is intended for general educational purposes. It's not to substitute any personal medical advice, diagnosis, or treatment. So please certainly do see your health professionals if there's anything that's unique to your case. So women are born with about 1 million eggs in each ovary, and by the time they reach puberty, they have about 300,000 eggs left. By the time they reach menopause, there are no active eggs left. From the age of 35 to 40, ovaries start to change, and the hormones estrogen and progesterone start to become less consistent, less regular than previously. You can call it erratic. Estrogen is primarily made by your ovaries before menopause, and to smaller amounts by your adrenal glands and your visceral host tissue. And its main roles are to control your menstrual cycles, to help with development of the secondary female characteristics, and to maintain bone health, prevent osteoporosis, and to help with your blood vessels, brain function, and skin. Progesterone is also mainly made by the ovaries after ovulation and in the placenta during pregnancy to help maintain pregnancy. It's also made in smaller amounts in your adrenal glands. And its role is to balance the effects of the estrogen, particularly in the uterus, to prevent unwanted endometrial overgrowth and thickening. This is what your hormones look like during your your reproductive years. We have the follicular phase and the luteal phase, and the first 2 weeks of your menstrual cycle during the follicular phase, the pituitary will release FSH, which will cause follicles to start to grow and release estrogen, and the dominant follicle will be primarily responsible for it. This then gives feedback to the pituitary gland and causes the luteinizing hormone to increase, causing that LH surge we see that causes the follicle to rupture and for the egg to release, and the estrogen levels will decline, and progesterone will get released by that a follicle that breaks down into a corpus luteum to really help grow the endometrial lining. And if there is, and this is really to get the uterus ready for implantation of a fertilized egg. So if there is no fertilization, both estrogen and progesterone levels will drop dramatically, and that will result in a period, in a menstrual bleed, which is considered day one of your menstrual cycle, and it will restart the process. This is a pictorial of the different stages of menopause and or your reproductive lifespan in years on the bottom, and your estrogen levels. And so pre-menopause, you'll see that you'll have fluctuating estrogen levels depending on where you are in your cycle. But what really happens is perimenopause really starts when your periods start to change and your hormones start to change, and those estrogen levels become unpredictable and they start to fluctuate. And menopause is characterized by your last menstrual cycle, where your estrogen levels are depleted by then. So perimenopause usually starts in women in their 40s, but for some women it can start as late as in their 30s, and it can last between 4 to 6 years on average, but it can be as short as a year or as long as 10 years. And it's characterized by unpredictable changes in the hormones. Fertility declines, but it's still possible to get pregnant until menopause is reached. Not all women will experience the symptoms the same way. 20% will have no or minimal symptoms. About 60% will have mild symptoms, and another 20% will have symptoms that are significant to do with the day-to-day quality of life. And so here is a summary of the physical and the emotional symptoms highlighted by perimenopause. They include changes in your menstrual cycles with irregular periods, joint aches and pains, hot flushes, night sweats, vaginal dryness and discomfort during sexual intercourse, change in libido, urinary problems, headaches, migraines, weight gain, and particularly changes in your body distribution, body fat composition, bloating, fatigue, and breast tenderness. Some of the emotional symptoms include difficulties with concentrating, so it's sometimes described as a brain fog, feeling, having difficulties with sleep, your sleep cycles, staying awake, or feeling like you're not refreshed, feeling more anxious, more irritable, and just not coping as easily with day-to-day events. Forgetfulness, mood swings, an increase in premenstrual syndrome can also occur, and an reduced interest in sex. Menopause occurs once you've had your final period, and you only really know you're in menopause 12 months after you've had your last menstrual cycle or last bleeding. The average age in Australia is between 51 to 52, but for most women, between 45 to 55, they will go through menopause. For some, it can be as late as up to 60 years of age. So let's talk about some of the symptoms in more detail. So hot flushes are described as burning, overheating, that is associated often with reddening of the skin and sweating. And it starts in the chest and abdomen and can spread up towards the neck and face, but can also involve the entire body. I think the first thing, if you are experiencing these symptoms, is to seek a review with your health professional and just ensure that there's no other reasons for these symptoms, such as an overactive thyroid, high blood pressure, infections, and cancers as well. How do you approach the management? So your conservative measures are to review your caffeine intake and your intake of spicy foods, alcohol, and stress. Look at your medication. Some medications can increase hot flushes. So for example, women taking tamoxifen or aromatase inhibitors for breast cancer can get side effects of hot flushes. Certain antidepressants can increase it. Certain blood pressure medications like calcium channel blockers or ACE inhibitors can contribute to it. And high doses of niacin or B3 can increase it. Now, what other treatments are there? So menopausal hormone therapy is very effective to help control symptoms, which we'll talk about in a little bit. And there are also non-hormonal treatment options for women who either don't want to be on menopausal hormone therapy or can't. They have contraindications to it. And these include medications. Veoza. Veoza is a relatively new medication. It's a selective neurokinin receptor blocker, and it blocks the action of a brain chemical called neurokinin B that's released in the hypothalamus, which is responsible for thermoregulation. So that is a new non-hormonal treatment option. Now, certain antidepressants at low doses are evidence-based as managing hot flushes. And then there are other medications like clonidine and gabapentin. Now, some of the other changes women experience include the bladder, the vagina, and the vulva. Some of the symptoms can include vaginal dryness, burning, and irritation, lack of lubrication during sexual intercourse, pain or discomfort, and then urinary symptoms such as recurrent urinary tract infections, incontinence, urgency, or pain. Some of the conservative measures can include using a vaginal moisturizer, exercising regularly to improve the blood flow to the area, using water or silicone-based lubricants to reduce the discomfort, and also hormonal treatments. So local vaginal pessaries or creams are very effective at treating very much the localized symptoms without necessarily giving you the systemic treatments, as well as menopausal hormone therapy that can help with all of these symptoms. Now, the bladder symptoms can include urge incontinence with the need to urinate frequently or suddenly or urgently, overnight having to toilet 2 or more times overnight, and leaking urine when coughing or sneezing or exercising. And Heather will talk more about this, but briefly, pelvic floor exercises are important. Again, looking at certain triggers like caffeine and alcohol, because that can increase bladder urgency, seeing a pelvic floor therapist, a physiotherapist who has expertise in this, like Heather will hear about, and also speaking to your GP again about either local estrogen therapies or menopausal hormone therapy. And if symptoms are not improving, also considering seeing a urogynecologist or a urologist with expertise in the area. Emotional changes can include mood swings, irritability, becoming more easily overwhelmed, feeling low or anxious. Again, exercise is key, having a well-balanced diet and getting enough sleep, and looking at treatments like menopausal therapy, antidepressants, and also cognitive behavior therapy. There's really good evidence that cognitive behavior therapy can help with some of these symptoms as well. And let's not forget, as I'm an endocrinologist, metabolic changes. When estrogen levels deplete, that shifts the body fat composition from the thighs and peripheries to the central, to the truncal area. So that results often with that fat redistribution and increased abdominal girth. And it can also, that lack of estrogen can increase the loss of lean body mass. And with reduced muscle mass, that can result in a reduced metabolic rate. So it's important to stay active and do regular physical activities to help counter these metabolic changes. Now, it also impacts your glucose metabolism. Now, insulin resistance can increase during these changes, particularly as there is that increased visceral adiposity. Estrogen normally enhances your insulin sensitivity. So with a lack of estrogen, you become more resistant, which can, if untreated or unmanaged, can progress to prediabetes or diabetes. So it's important to have a well-balanced diet. And if you are experiencing some of these changes or concerned about some of these changes, seeing a healthcare professional to have it reviewed. Now, what about your cholesterol levels, your lipid metabolism? So there is a predisposition to increase in your LDL cholesterol and your total cholesterol, which is the bad cholesterol, the LDL, and a reduction in your good healthy HDL cholesterols, and a rise in your triglyceride levels, which can then predispose you to increased risk of heart disease. And then that lack of estrogen accelerates bone loss as well, which can predispose you to osteopenia and osteoporosis, and also can impact your calcium absorption. So how do we diagnose perimenopause? Because the hormones change from day to day, blood tests may not necessarily help with the diagnosis because they may be normal one day, high next day, low next day. But certainly that constellation of symptoms of changes in your menstrual periods and the symptoms of physical and emotional we've discussed help with the diagnosis. And keeping a record of your menstrual cycles is helpful with that. So let's turn our attention to menopausal hormone therapy. So this is a combination of treatment with hormones to relieve the symptoms of menopause. So as mentioned during perimenopause, your hormones are fluctuating. So it's not stopping the highs, but it's stopping the lows in your hormones. So it's giving you estrogen and or progesterone together, depending on your circumstances, regularly. So there are different types of menopausal hormone therapy. So estrogen-only therapy is suitable for women who have had a hysterectomy, so they no longer need progesterone. Progesterone is important to counter the effects of estrogen and to prevent endometrial lining from getting too thick, which can predispose you to endometrial hyperplasias and malignancy. So it comes either as daily tablets, and some of the names, brand names are Proganova, Estrofem, and Premarin. There are transdermal patches that are applied and changed every 3 days, so twice weekly, that are worn continuously, either on your abdomen or over your buttocks area. There is transdermal gel, estrogel or Sandrina, that's applied every day. And then there are the transvaginal creams or pessaries. And those are really for the localized symptoms, as I mentioned. So some women may need systemic menopausal hormone therapy, and if that's not relieving their local symptoms, they may also benefit from the localized vaginal treatments. And the estrogens, they come in low, medium, or high doses, and it depends on what stage you're in and what your symptoms are. Whether your health professional would put you on a low or a medium dose of estrogen when you start on treatment, with then monitoring of response to it. Next, we have combined estrogen and progesterone therapy. So this is for women who still have an intact uterus. And so we have some sequential or cyclical menopausal therapy, and we have continuous combined therapy. So sequential is where estrogen is given continuously, and progesterone is given for 10 to 14 days of 28-day cycle. And it's meant to really sort of, I guess, mimic what a natural menstrual cycle would be like, and you would be expected to have a light withdrawal bleed when you're off the progesterone. The estrogen can be given as a tablet every day or as the transdermal patches, or there are combination patches with estrogen and progesterone, and or it can be given as a gel and micronized progesterone, as shown in this picture here. And some of the preparations, as mentioned here, are famostin and trisequence. These are tablets, Estrogel Pro, which is gel and prometrium patches. Continuous combined therapy is taken every day without a break. So it has the same dose of estrogen and progesterone throughout the continuously. And it's intended for women who are generally postmenopausal to really just prevent that endometrial lining from getting too thick with unopposed estrogen. And the combinations of estrogen, so there are synthetic estrogens and progestogens, and there are more body identical estrogens and progestogens. And there is a real shift nowadays to trying to use more of the body identical preparations that are considered to be safer preparations. There is also tibolone, which is a synthetic hormone that has estrogen, progesterone, and testosterone activities, and it's given as once a daily tablet. And then there is testosterone, which is indicated for women who have sexual hypofunction and low libido. And it's intended to be in addition to menopausal hormone therapy, where it hasn't given enough relief of the symptoms. Regular blood tests are needed to ensure you're not on too much. Some of the side effects on testosterone can be acne, a deepening of the voice, hair growth, and mood changes. It's really indicated just for hypofunction, hasn't been shown to help cognition or mood at this stage. And it's a daily transdermal cream. The benefits of being on treatment include relief from the symptoms of the vasomotor symptoms, the hot flushes, the night sweats. It can improve sleep and mood, and it can protect against bone loss and fractures. The greatest bone loss is really a year before menopause and the first 2 years after menopause, with approximately almost 7.5% loss at the spine in bone density and almost 6% at the hip, at the femoral neck. And then thereafter, about 2.5% is lost a year at the spine for the first 2 years, and then about 0.7 per year. So it's now indicated for women who have osteoporosis and are around the time of menopause to really help prevent from further bone loss. It can help with local symptoms, the vaginal and urinary symptoms. And it also has been shown to improve, has cardiovascular protection if started within 10 years of menopause. If started later, we don't see the benefits of cardiovascular protection, and it can help with that disorganized lipid profile that we see around perimenopause. So there are a lot of benefits, and it also helps with cognition. I don't think I mentioned that. It hasn't been shown to reduce the risk of dementia, but it can help with the brain fog and the difficulties with concentration women experience. Now, what are some of the risks of being on treatment? So let's talk about blood clots and strokes. So the risks depend on the type of hormone replacement therapy, the dose, and the duration of treatment, as well as your individual factors. Oral preparations of estrogen do increase risk of stroke, and it's thought because they increase the clotting factors that can increase your blood clot risk. The transdermal preparations, the gels and the patches, because they are delivered directly into the bloodstream, they bypass the liver metabolism. They have not been shown. So at the low to medium doses, studies have shown that they do not significantly increase your risk of blood clots. What about the progesterone preparations? As I mentioned, there are synthetic and there are more body identical ones. The stroke risk will differ based on the type of progesterone. The synthetic preparations, particularly with medroxyprogesterone, do have contribution to vascular risk. Micronized progesterone or prometrium, that is, for example, used with Estrogel Pro, is vascular neutral. So it does not appear to increase your clotting risk and appears to be safe. What about the risk of breast cancer with menopausal hormone therapy? So this is a position statement that Australian Menopause Society put out about it. And it looked at 5 years of treatment with menopausal hormone therapy from the age of 50. And they looked at between 50 to 69, the risk of breast cancer. So when they looked at continuous combined menopausal therapy, the increase from baseline of 3 in 50 women was one extra case in 50 women. For the cyclical combined therapy, the baseline risk was 4 in 70 with one extra case on menopausal therapy in 5 years. And for estrogen-only therapy, the baseline risk was 13 in 200, with one extra case in 200 women. Now, if you look at 10 years of use of menopausal hormone therapy, basically there was one extra case for each category. So for continuous combined therapy, it went from 3 in 50 to 2 extra cases in 50. For sequential menopausal hormone therapy, it went from 2 extra cases, 4 in 70 to 6 in 70, 2 per 70. And then for just estrogen only, it went again by 2 extra cases for 2 in 200 women. So if you compare it to other risk factors for breast cancer, other risk factors include having more than 2 standard drinks of alcohol a day, having your first child late. Women over 35 will have a higher risk. Those who are overweight or obese, or those reaching menopause in their late 50s. So the breast cancer risk is relatively small, but I think the type of progesterone you're on matters, and the duration. So currently, the recommendations, Breast Screen Australia recommends women are actively invited to do mammograms between age of 50 to 74 every 2 years. But you can start doing them from the age of 40. They are covered, you're just not actively invited to do them. And women above 75, if they would seek treatment for breast cancer, are invited to also continue to do regular breast mammograms. Now, for younger women, because younger women tend to have quite dense breasts, a mammogram may not be enough. So maybe more beneficial to do a mammogram and a breast ultrasound at the same time. Who should not be taking menopausal hormone therapy? Well, anyone who has current, past, or suspected breast cancer, because a lot of breast cancers are estrogen and or progesterone positive, they should not be on it. If you have any other suspected estrogen-dependent cancers, such as uterine cancers, they should not be taking it. If you have undiagnosed vaginal bleeding, it should be investigated first. Or if you have untreated thickening of that uterine lining, that could worsen with being on menopausal hormone therapy, that should be investigated first. Now, women who have thrombophilia, so for example, factor V Leiden mutations, I think it's a case by case and depending on your particular situation as to whether it's appropriate or not. As I've mentioned, the clotting risk is the concern around menopausal hormone therapy. And if you've had previous DVTs, PEs, you're going to be at high risk of having them. So I think that needs a case-by-case assessment. If you are someone who's heterozygous and has never had a blood clot, whether you're appropriate to have it or not. And anyone with untreated high blood pressure, heart disease, strokes, or active liver disease should probably be on it, or be at least consult with a health professional to look at their individual risk profile and risk versus benefit profile. So in summary, symptoms of perimenopause can range from minimal to quite severe. There can be a range of physical and emotional symptoms. And I think it's important to seek help if you have these symptoms. And I think if you feel you're not being heard by your GP about it, there is Australian Menopause Society on their website. You can search any GPs in Australia who have an interest in menopause and seek a health professional who has an understanding and has an interest in this area. Jean Hales for Women's Health is also a fantastic resource, and Royal Australasian College for GPs as well. So that concludes my portion of the talk, and I'll be very happy to take questions later. Thank you. Thank you, Monika.
Thanks, Dr. Monika. The next speaker is Heather Minnich. Heather has been a passionate physiotherapist for 13 years and spending the last decade Last decade of that working women's pelvic. Heather currently works at her health physiotherapy in Richmond, a private practice clinic devoted to supporting women through all ages and stages of life, including perimenopause. Heather has also previously worked at the beginning of her career in a sports-based private practice where she worked closely with netball athletes, a natural fit given her own background playing netball at state level. She also concurrently worked at Westmead Private Hospital on both the maternity ward and post-operative surgical ward. Outside the clinic, Heather has 3 kids who occupy the majority of her spare time, but loves to fit in running and strength training amongst the juggle. Heather's passion lies in helping women live symptom-free lives and loves working at the intersection of women's health and exercise. She's committed to creating treatment and mentoring plans that empower women to continue doing their activities and sport they love without being held back by pelvic floor symptoms. She's a strong advocate for education, encouraging women to understand their bodies, symptoms they might be feeling, and that while these symptoms may be common, they're not something to suffer through in silence. There is help, there are options, and movement is always possible.
Hello, I come with a bag of props, so I'm just going to pop my props down over here for a moment. Back to those. And oh, sorry. That's just going to irritate. Okay, sorry, technology. Let me just present. There we go. So my name is Heather, and tonight we are going to talk about perimenopause and the pelvic floor, any symptoms that you might be experiencing. I tend to get a little bit passionate about women's health when I talk, so I'm going to try and keep my focus on perimenopause. But we see women in the clinic every week who are going through perimenopause. We love treating them because we can often make such a big difference to their symptoms that they're experiencing. And tonight I want to talk a little bit about the different symptoms that you might experience, some options that you can practically try just in your day-to-day weeks to try and change your symptoms, and then also some ideas about what it would look like if you came and saw a women's health physiotherapist and what we would do in our clinic within that as well. So I love being able to change the different symptoms that women experience. I had some notes because I tend to go off topic and I can't see them, so I'm going to roll with it. But I love the idea of being able to empower women who are getting all these different symptoms and to give them an option to change them. It doesn't have to be something that holds you back from exercise. We love keeping women moving. We love keeping women exercising, and it's so important for the whole health benefits of your body that there are more benefits than risks to keeping you moving. Just because you're having pelvic floor symptoms, we want to work out ways to be able to navigate through those symptoms. So at the clinic, we would see women who are going through perimenopause every week, and I love seeing them because we can make such a change to your symptoms. It's often symptoms that women have put up with for a really long time. They haven't done anything about it. It's started to get a little bit more worse, or it's impacting them a little bit more day to day. And they're thinking, am I reading into this? Is this too much? And often the answer is no, you're not reading into it. There's something that can be done. And so I want to outline a little bit tonight around some different symptoms that you might experience and what we can try and do about those symptoms within the clinic. So perimenopause, as Monika has perfectly summarized, I don't need to go into what perimenopause is. You understand that it's that transition to periods and menstruation cycle ceasing. But it can have a lot of influence on the pelvic floor, and there can be a lot of different symptoms that can pop up for women as they transition into menopause. So it can be things like urinary symptoms, having to rush to the bathroom, leaking when you're on the way to the bathroom, not feeling like you're fully emptying. It might be leaking with exercise, which can put a lot of women off exercise, unfortunately. It might be a lump or a bulge sensation or some vaginal heaviness symptoms that start to pop up that once were intermittent but start to become more daily and more frequent. It might be sexual pain, which the fire emoji is often how women describe it in the clinic, burning, vaginal dryness, a lot more new onset of discomfort that doesn't make you want to engage in sex. There can also be bowel changes as well, and all of this can be influenced by those hormone changes within perimenopause that start to make women more symptomatic and impact on their quality of life. So the anatomy, this is, where my props come in. So the pelvic floor muscles, if I'm going to be talking about this, I want you to know where your pelvic floor muscles are.
So they sit at the base of your pelvis and they support 3 organs that sit inside your pelvis: your bladder, your uterus, if you still haven't had a hysterectomy and the uterus is still present, and your bowel. And so the job of the pelvic floor muscles is anything red you can see here is your pelvic floor muscles that sit in the base of your pelvis. And anything red you can see on the outside here are also the pelvic floor muscles that sit at the base of your pelvis. Their job is just as important to hold things in as it is to let things out. So when they squeeze and lift, they keep urine in your bladder. They tighten the walls of the vagina and can make an orgasm more intense and more enjoyable. They can hold in a fart or a bowel motion, but they also, when functioning well, they also need to relax to let out your bladder and empty your bladder effectively and to be able to pass bowel motions effectively. So their tightening is also just as important as their ability to relax. And so we're going to talk about the pelvic floor and its influence, but I want you to know where we're talking about because it's not often something that's spoken about. That's going to be my soapbox moment later, but we're going to get to that. So let's start with urinary function. What's normal for urinary function? I want you to understand what's our sort of baseline that we're like, no, this is normal. This is maybe a bit out of the ordinary. Daytime, if you're adequately hydrated and not sculling a lot of water, you should be able to last 2 to 4 hours between doing a wee. Less frequent than that, we're starting to wonder what might be happening. Overnight, as Monika had mentioned, up to 2 times at most overnight would be normal. Anything more frequent than that might be a change. You should be able to walk calmly to the bathroom and you should be able to choose when you go to the bathroom. It should not be urgency that's forcing you to empty. You should feel fully empty after you're finished doing a wee, and you should be able to cough, sneeze, and lift without leaking any urine or bowel motions, if we're being honest here as well. So when might it be time to seek help? What symptoms would we start to expect that we would see within the clinic? Well, it might be frequent rushing to the toilet with little output or maybe no urine output. It might be rushing to the bathroom because you're worried that you're going to leak if you don't go straight away. It might be leaking on the way to the toilet. It might be hesitancy to initiate your bladder flow. It might be that you never feel fully empty once you're finished going to the toilet to empty your bladder. Or it might be leaking with coughing or sneezing or lifting or exercise. It might be an activity that makes you leak. So they might be symptoms that we would often see women for in the clinic. So I want to be practical on this and I want to give you some practical options to try for what you could do to help. Try these first. If it's still not changing, that's probably a sign to come and see us or a women's health physio in your area. I don't mind who you see. So if you're rushing to urinate or you've really frequent urination, what are some things that you can do? We know the first thing that when you feel this urge, you want to rush, you want to go really quickly, but we want you to take a couple of slow, deep breaths. It's going to feel like the exact opposite of what you want to do, but it's going to help you to be able to actually inhibit your bladder urge and to suppress that urge a little bit. You'll notice that as soon as you rush, it doesn't get any better. It often gets a lot worse. So if we can take slow, deep breaths, it's going to help to reduce the intensity of that urge that you're feeling. And then with that calm state you're in, you're going to walk calmly to the bathroom. When you're rushing to the bathroom, it's only making that bladder intensity much more urgent. And then as you're going, if you're feeling that really strong urge gets overwhelming, a really strong toe curl, like you're scrunching your toes under to try and lessen the bladder urge. It sounds like the most bizarre thing, but it actually has links. The nerve that supplies your bladder also supplies your toe flexors. The brain can't concentrate on 2 things at once and it suppresses the urge. Next time you feel that strong urge, I want you to think of me in your head with my toe curling image. You're going to try it for a good 5 to 10 seconds and see if it lessens that urge and intensity, because often it's the most effective strategy out of the ones we know from research help dampen bladder urgency. It's probably the one that I find is clinically most effective for clients. Other options that you're going to do, your position on the toilet. Do not hover over the toilet seat. You are not emptying your bladder effectively if you are hovering over the toilet seat. We want you to sit as much as possible and in a demonstration state, yeah, they can still see me, elbows on your knees whenever you're sitting on the toilet. We want that lean forward position to optimize your bladder to empty as effectively as possible. The other option is the toilet dance. So if you feel at the end of emptying your bladder that you don't feel quite empty, you're like, there's still something more in there, but I just can't get it out, try lean forward and backwards toilet dance when you're on there, a bit of a wiggle side to side, and see if actually facilitates that last little bit of emptying. It changes the position of the bladder. It relaxes the pelvic floor to allow the urine to come out completely and can be a really effective strategy. So you're going to think of your disco ball when you're on the toilet and trying a bit of a dance, and you'll actually find that often when you're not feeling completely empty, it can be a really helpful strategy. At least you've done a little bit of extra movement that day. So what the other options that we can try for leaking with a lift, a cough, or a sneeze. You could try and exhale with effort. Often breath holding on a lift will put a lot of extra pressure on your bladder and can cause leaking. You could try changing your squat technique. It might be something as simple as normally you back rack a squat or you front rack a squat, and maybe you're changing around with the position of where the weights are sitting and finding if that creates less pressure into your bladder and makes the leaking a little bit better. Lara and her team are going to be much more specific around that, but trying different things. It might be a narrow stance that's more effective for you compared to a wider stance, and just being willing to try different things within your technique that don't optimize your performance, but might reduce your leaking sensation or the amount of leaking that you're getting. The other thing, particularly with impact activity, is staying relaxed. Nobody really relaxes into response of a fear of leaking. They'll tighten, they'll brace, they'll really switch on everything as much as they can, which often creates a lot more pressure on the bladder and doesn't allow any shock absorption. So you're landing on a really firm surface. For skipping, often a simple cue like softening your skipping or thinking about landing on a trampoline as opposed to really firm, hard skips can actually reduce a lot of leaking for women as well. It's something simple that's worth a try. The other thing is a pelvic floor muscle squeeze. We're going to do a little practice of that later on, but sometimes bracing, particularly more for known movements like a lift or a cough as opposed to skipping, can be a really helpful strategy that for some women does reduce their leaking. So what would we do? These strategies you've tried hasn't made too much difference. You're wanting to come in and see us, what would we do? One of the first things we sort out for women is constipation. Constipation has such a big impact on the bladder and on bladder urgency and on bladder frequency that can often help to reduce a lot of bladder symptoms just by managing the bowels regularly emptying. We address poor bladder habits. The key in the door when you get home, always rushing to the bathroom to make it in time, or when you're hearing running water and you've got to rush to make it in time to the toilet because the running water triggers that urgency. They can be poor habits that get created by the bladder that will start to delineate and take a really thorough history of when you get your urgency, when are you rushing, what are the symptoms that you're feeling, and trying to create slightly better bladder habits. We look at the pelvic floor muscles. Like we said, we want them to squeeze as much as we want them to relax. What's the issue that might be going on here? Because leaking can happen with weak pelvic floor muscles, but also with tight pelvic floor muscles. And so in some women, we need to work out which one is it that's actually causing them to leak and assess that effectively. The other option that might be a little bit more outside the box, because the pelvic floor muscles are designed to respond to tension. They're designed to keep organs in the pelvis. When there's a lot of pressure coming from tight ribs, tight abdominal muscles, excessive gripping, it can put a lot of pressure down into the pelvis itself, causing a lot of pelvic floor muscle tightness. So in some women, what we're actually doing to treat their bladder symptoms isn't within the pelvis itself, it's modifying the pressure that's being placed down onto the bladder and the pelvis itself. We do bladder retraining drills for those moments where you feel just undeniable urgency that doesn't seem to make sense. And the other part within this is, as Monika touched upon, the bladder sensitivity as estrogen declines in menopause is really significant for a lot of women. And we find that an estrogen referral from their GP, it's a script that's required from their GP for topical estrogen applied around the vagina, can actually reduce a good chunk of bladder symptoms in women who are peri or post-menopause. The next topic we're going to talk about is that lump or bulge sensation. It might feel like a vaginal lump or bulge. It might feel like a dragging, heavy feeling around your vagina. It might feel like a tampon kind of just isn't sitting right, even though you don't have a tampon in. That can be how sometimes women describe the lump or bulge sensation that often is triggered by that drop of estrogen or that lack of estrogen in perimenopause. When might it be time to seek help? Well, there's actually 3 different types of prolapse that can occur. So do I have a pointer on this? Yes, I do. So you've got 3 organs that sit inside your pelvis, your bladder, your uterus, and your rectum. And so there can be prolapse where the bladder drops down into the front vaginal wall, which might be that incomplete emptying sensation or that urgency or just feeling like you're having to rush a lot or getting unexpected bladder leaking. There can be uterine prolapse, where the uterus drops down and descends and sits lower inside the vagina itself. That's typically more just a lump or bulge or heaviness sensation that women would describe that as. Or there can be where the rectum drops down into the vaginal wall, which might be for a lot of women that incomplete emptying of their bowels, or feeling like I need to empty my bowels. There's something there, but it just feels stuck, can't get it out. So what would we recommend that you could try doing if you're feeling this lump or bulge sensation? Managing your constipation. It's going to come back to constipation a lot tonight. Managing constipation and straining. If you're sitting on the toilet straining and pushing with all of your might to try and empty your bowels, it's not going to be very helpful for your vaginal walls either. It's going to put a lot of pressure and often accentuate that lump or bulge symptom. So making sure that we're trying to think about not straining and doing what you can to try and maintain bowels, which we're going to get to at a later point as well. Again, changing your lift technique. If you're getting a heaviness sensation with a lift, what could you do to modify the lift? Could you lighten the weight and see that it lessens it? Could you play around with your heel tilt position, your pelvic tilt position, and being able to modify your rib position? If you stand a bit more open, does it make a difference to the heaviness that you feel? And playing around with different postures and positions to see if it lessens your symptoms. The other thing that's really helpful is noting the pattern of your symptoms. Is it more at the end of the day? Is it more when you're constipated? Is it more when you've done a particular exercise or activity? Starting to note that pattern of your symptoms and how they're presenting is really helpful for us because it helps us work out what might be causing it, but also for you so that there's a bit more predictability to why you're having these symptoms and paying a bit more attention to when you're getting them. So what would we do? Well, we assess and stage prolapse. So in terms of my pelvis and my model again, we can actually take a measurement on the outside of your vulva from mid-urethra through to mid-anus. And this measurement actually has a normal range of 6 or 7 centimeters. It's really highly correlated with prolapse when it's over 7 centimeters. And I appreciate, sorry, I've just gone straight into vaginal exams. That's part of what we do as pelvic floor physiotherapists. Muscles sit inside your vagina. So to be able to assess your muscles effectively, that often will involve, if you feel comfortable with that, a vaginal examination, purely because it's going to give us so much more information. If you went to a physio for back pain and they never looked at your back, you'd probably think they were doing an irresponsible job. If it's pelvic floor symptoms that you're coming in for, we want to assess and know what's going on with that with your consent. So we assess and we stage for prolapse. We look at which vaginal wall is causing your symptoms, how much descent are we seeing of these vaginal walls, and what stage would we give the prolapse, because it determines what management strategies are going to be most effective for it. We look at pessaries, another delightful thing that I get to bring in as a prop. Let me preface them with, if you're going and doing exercise, you'll often wear a sport bra to support your breasts, right? And when you're going to do impact work, you want that support so that they're not moving around a lot. The same can go with vaginal walls. If you have excessive movement of your vaginal walls, using these silicone support devices, which come in a variety of shapes and sizes and widths, that sit inside the vagina, similar to a tampon, they fold and insert, and they look quite intimidating. When they are in the right place, no one can feel them. No one has a lump or bulge sensation when they are sitting in place, and they can be like a support device, like a bra is for when you're exercising. They can be a support device for vaginal walls that for a lot of women mean they have no symptoms when exercising, no leaking when exercising, and no lump or bulge. And so they're fit, and we use them based off different sizes and different styles or designs, depending what symptoms women are having. A lot of women have never heard of these, but they are a really common medical device that physiotherapists who have been trained and have qualifications can fit, like myself, or that obstetricians and gynecologists will often fit or use as well. And they're really effective conservative strategies that don't require surgical management to try and help reduce that lump or bulge sensation for a lot of women. The other thing we look at is that thoracic spinal rib cage. It always comes back to the ribs. When there's extra pressure being placed down into the pelvis that makes that lump or bulge symptom worse, we can assess and manage that abdominal pressure that's coming from that symptom and contribution as well. And for some women, we do teach them pelvic floor muscle exercises, strengthening exercises, that they've got better support for their organs and there's not as much descent that gets pushed down in there as well. Sexual pain. That's the next topic we're going to talk about. Particularly common with that lack of estrogen or drop and decline in estrogen with perimenopause. It can present like increased vaginal dryness, painful intercourse, increased pelvic floor tension, but it also creates this cycle with when you're anticipating pain as a pelvic floor muscle tightening, then it is painful, and then you tighten your pelvic floor muscles further, and it just kind of creates this vicious cycle of pain and discomfort with intercourse. So when might it be time to seek help? If you're avoiding intercourse due to pain, that's probably a pretty good sign. If you're anticipating pain with sex, that's probably another sign that it's becoming a bit more symptomatic and impacting your quality of life. And if you're unable to tolerate any insertion, that's also a really great time to come and see us as well. So what could you try? Monika talked a little bit about lubricant before. A lot of women aren't using good quality lubricant, and it can make a big difference from a vaginal moisture perspective, as well as from a lubrication perspective with intercourse. The one that we actually like, there's a few different types of lubricant, which is a whole extra conversation, but the one that we really like, there's oil-based, there's water-based, and there's silicone-based. So there's 3 different types. If women aren't using condoms anymore, which they often are not once they're in menopause, oil-based lubricant is really well tolerated for women for vaginal dryness. The one that we really like is called olive and bee. It's just olive oil and beeswax, but the oil-based lubricants last for a lot longer. They're less irritating. And I find for women who have ongoing repetitive thrush or UTI infections, it seems to not be an issue when they're using this as their lubricant. Using a good quality lubricant is a really good way to start to see if that changes the sexual dryness or the symptoms that you're getting. Avoiding soap in or near the vagina. A lot of women, it's just, again, this is the education that we don't often receive. Using soap inside the vagina is not encouraged. The vagina has its own microbiome. It doesn't need to be disrupted by soap. You can use scent-free soap on the vulva, on the outside itself, but using soap inside the vagina can be really irritating and can cause some pain and discomfort with intercourse. But often when we stop that for a lot of women, it tends to reduce a lot of their symptoms or discomfort. The other option around this is your GP. It all comes back to estrogen. Your GP and using topical estrogen for a lot of women, it can actually reduce a lot of their sexual pain and discomfort quite quickly. So what would we do? Often we talked about the pelvic floor muscles can get quite tight when you're anticipating pain or when you're getting discomfort with sex. So for a lot of women, we're teaching them pelvic floor muscle training on mainly focused on how to relax their pelvic floor muscles, because we know that when they are tight, it's really hard to achieve penetration and can be really uncomfortable. So we're teaching women pelvic floor muscle training, but a lot with the focus of how to relax their pelvic floor. We do a lot of education. A lot of women are just not taught their own anatomy. We're really good at knowing male anatomy, which is obviously very external. Female anatomy and internal anatomy can be hard for women to know even where to identify where their pain is coming. Is it their clitoris? Is it their urethra? Is it their labia or their vulva? And they don't have the anatomy or the knowledge to know where to identify that around, which I think is really important for us to know, and also for all of our daughters to know, because we're not taught a lot of this language to be able to express where we might be getting this discomfort. The estrogen referral with the GP, if that's not part of their management already, can often be a really helpful place for women to start. And also noting that with sexual pain, it's never just one thing. It's never just the physical symptoms. There's often a multifactorial contribution with sexual pain. So things like emotional load or psychological load or previous relationship strain, all of these different things can play different roles. It's not often just the physical pelvic floor. And so making sure that women are, 1, aware of that, and 2, have pieces in place to help manage that effectively, because we know that multidisciplinary input for sexual pain is what creates the best outcomes. Our last one, constipation. So I told you it all comes back around to this as well. Inconsistent emptying. So constipation is where there's just consistency to your bowels, no consistency in timing. So the time of day that you empty, the number of days in between when you empty, or the actual consistency of your bowel motions. If there's not regularity to that, then we would argue that that starts to trend towards constipation, because there's not that regular rhythm that your bowels have gotten into. So when might it be time to seek help? I guess if we think about it in the context of how it influences all of these other symptoms, Constipation can have a major impact on prolapse symptoms. So if there's constipation and lump or bulge, that might be a time to investigate. If there's constipation and bladder symptoms, that might be a time to investigate. Or just that idea of being able to feel like the bowel motion is there, your consistency is good, but you just can't empty. It doesn't feel like it's coming out. The pelvic floor muscles can play a role in that in terms of allowing them to relax, to let the bowel motion out as well. So what could you try for your bowels? Drinking enough. It's a pretty obvious place to start. We know when we drink more, the consistency of our bowel motions is softer, it's more hydrated, it's easier to having some form of regularity with the timing. We know that a really simple trick we often use for a lot of women is that your bowels are most active in the morning after you've eaten breakfast. So sitting on the toilet at some point within that hour of having eaten breakfast and having got up can often find that even if you didn't have the urge to empty your bowels, when you sit down and actually relax, you'll find that often an urge can start, or we can start to create a bit more regularity and habit to the bowels. Position. So just like we talked about when you're sitting on the toilet to do a wee, elbows on your knees, we want the same for bowels, but you'll notice that my delightful diagram has a step stool. When you're sitting on the toilet, we want your knees, when you're emptying your bowels, we want your knees higher than your hips. It just allows your pelvic floor to relax enough and the anatomy of your bowels to relax enough to ideally optimize their emptying. So the little step stools that you used with your kids when they washed their hands and needed to, toddlers to reach to the sink, it's perfect height. Something like that underneath your feet when you're emptying your bowels, leaning forward with your elbows on your knees and just relaxing, blowing out, not straining and forcing and tightening, just often blowing out and just exhaling is enough to be able to optimize the emptying a bit more. Give it a go if you haven't tried it. The last thing that can be sometimes really helpful is perineal support. So some women, when particularly for that symptom where you're finding that I tried to empty and it just feels stuck, you can't get it out, not because it's firm or too hard, but it just feels a bit tricky. We're going deep here, guys. I want you to try wrapping your hand in some toilet paper and supporting over your perineum. So you might sit down and empty your bladder. Then when it comes to emptying your bowels, wrap your hand in some toilet paper and push up and support over your vulva, your urethra and vagina and your perineum, just in front of your anus. And often that bit of support, you might find that it allows to optimize the emptying of your bowels as well. You can do the toilet dance, you can try some perineal support. You'll be thinking of me over the next couple of days when you're on the toilet. So what did I do? If you came in and constipation was part of your history that you're reporting to me, we would look at getting your stools a little bit more consistent, which can also be in consultation with dietitian or GP or the pharmacist around what might be the best products to use for that. Creating habits for your bowels so there's consistency to that. We actually teach women how to properly empty because the pelvic floor muscles have to relax to be able to let out a bowel motion. Sometimes we're teaching women the most optimal technique that doesn't involve a lot of excessive straining to be able to empty, and use an ultrasound machine for that. We're also going to want to optimize the positioning based off your body, your anatomy, what that looks like to be able to try and help facilitate the most effective emptying. So it's not remaining with bowels putting pressure on your bladder or on your vaginal walls. So let's get practical. We are all going to try the pelvic floor squeeze. I've talked about pelvic floor muscle squeezes, but it's often something that's not thoroughly understood. And while they are internal muscles, and for us to properly assess the muscle function in internal examination is most optimal, it should feel a lot like cutting off the flow of urine midstream. It's an easy way for you to try to see if your pelvic floor muscles are functioning effectively. Once you've emptied at least half of your bladder, we don't want to do it with an excessively full bladder. You're sitting on the toilet, you've emptied half your bladder, try and squeeze and see if you can cut off the flow of urine. That's that action of the pelvic floor. Another way of thinking about it is if you're holding in a fart or a bowel motion, that squeezing and lifting action that you're all trying, but I can't see. We all know you're trying right now. You should be able to squeeze and lift and then drop and relax. And so if we all try it now, that fart squeeze or that wee squeeze, another helpful way is if you're sucking up through your straw at your vagina. It sounds really weird, but you'll get what I mean when I say that. And then relaxing and letting go. So we should be able to either feel that squeeze and lift and then that drop and let go. You might feel a bit of a squeeze, but no let go, or you might feel nothing. And that might be a sign that maybe your pelvic floor muscle function isn't as optimal as it could be. But that's what we're going for when we're talking about that squeeze for a cough or a sneeze, that wee squeeze or that fart squeeze. Rib releases, that might be something as simple when we talk about all that abdominal pressure and tension that might be generated through there. It might be something simple like foam rolling with your ribs when you're lying on your side and rolling up and down foam rolling, or just an open and closed book stretch. Or it might be a child's pose stretch where you're just breathing, relaxing, letting go around your abdomen and holding for 5 breaths from one side. So there can be some really practical things that you can try if you feel like you've got a lot of abdominal tension, thoracic stiffness. The last thing you can play around is with your squat options. We talked about different squats, and because you've been sitting for long enough, everyone's going to stand up. This is our final thing we're going to do together. We're going to get real practical. And so what I want to try is just a squat, one where you breathe and one where you're breath holding. And I just want you to feel the difference between the two. So I want you to do whatever feels comfortable for you. Feet narrow, feet wide, whatever it might be. You're going to go down like you're about to sit down on your chair, but then you're going to touch and come back up again, right? So this time, I want you to try with a pelvic floor squeeze. I want you to think about that wheel fart squeeze. You're going to come down to touch the chair. It'll relax a little. Then you're going to squeeze as you come back up again. You might be able to feel a squeeze. You might not. That might be something that you try on your next squat if you find that you leak with a squat. The other way that we're going to try is with a breath hold versus with a breathing to see if we can reduce a bit of tension. So I want you to hold your breath. I'm going to do a squat again. See how it feels. Note the pressure at your pelvis. This time we're going to breathe in as we go down and breathe out as we come up. So breathing in to go down and then blowing out as you come up. And generally we feel there's a lot less tension in the pelvic floor, a lot less tension in your abdomen when you're doing a bit of breathing with it. So you've now all practiced it. You can try it at your next exercise class or with your next picking up of kit items off the floor. Grab a seat. Had to keep you moving. You've been sitting for long enough now. But hopefully that leaves you with some practical things to try. Some idea about what symptoms might be common, but something can be done about them, and some practical tips to try and see what change that might make. If not, come and see us. That's the first.
Thanks, Heather. Our next speaker doesn't really need an introduction. It's Lara Perrett. Lara has worked in the health and fitness industry for 25 years and brings a unique blend of expertise in both physical and mental health. Lara has a Bachelor of Social Work with the University of Sydney, specialising in addiction, philosophy and eating disorders. She has worked as a therapist in private practice, both focusing on depression and anxiety management. This foundation has been invaluable in her work as a coach and women's health advocate. Lara is also a certified strength and conditioning coach, women's health practitioner, nutritional coach, and Pilates instructor. She is passionate about empowering women, especially through premenopausal and beyond, to embrace the benefits of constant resistance training, mindfulness, balanced nutrition, and stress management. Her approach is focused on fueling, not restricting, and creating change that women are realistically sustained. At MaxFit, she and her team have built a supportive community where women can discover strength, confidence, and well-being at every stage.
Hello, everyone. Just let me get this sorted before I. Okay. Oh, can I get you guys? Wait 1 sec. Has anyone got questions? So because the reason I'm asking is that we're all going to do a bit of a panel after we've finished. And if you haven't asked questions, that's okay. We will let you ask the questions in person, but sometimes people tend to get a little bit nervous or embarrassed. So that's why that code is there. If you have a question that is perhaps slightly embarrassing, not that it would be, I mean, it's a safe space, but still, especially after talking about constipation and what have you. And squat technique, which we'll come up with a little bit later. I just wanted to talk to you a little bit tonight about what it means to be strong. And I think that if anyone is going through perimenopause or has been through perimenopause, you'll know how much we need to dig deep and try and be strong. So tonight it's about navigating this perimenopause using strength, nutrition, and mindfulness. Just a little bit about us at MaxFit. I guess we don't like to take ourselves too seriously. And I think when we first started Max, we wanted it to be a space that was safe for people to be able to explore, I guess, a little bit more about themselves with their health, but not just their physical health, their emotional health, spiritual health, and of course, mental health. So our trainers are all certified in mental health, but not only that, we have trainers who are very good at connecting with people. And if you are a MaxFit member, you will know that about our team. I think one of the things as you walk in, we actually have a little thing about our gym and how it's a place for mental health for someone struggling. It's confidence for someone building it, recovery for someone battling addiction, and social interaction for someone who feels alone, and a physical health for someone who is fighting to hold on to it. So I think, you know, over the years, exercise has really been medicine for me and for our family. So obviously I am a mum, I've got 4 kids and a husband and dogs and ferrets and all those things. But one of the things that we're really passionate about is to see not just women embrace health, but is also to see kids embrace health. So we have a great program here for teens and for kids, just trying to help them understand the importance of being active. As mentioned before, I'm an accredited mental health social worker, and I guess that's, you know, one of the reasons that we are so passionate about mental health is just to see the difference that that can make in people's lives when it is embraced. I just want us to shift a little bit because, like me, most of you would have been brought up in 80s, 90s, I'm assuming. And if not, lucky you, because you're still really young. Do you guys remember Kate Moss, nothing tastes as good as skinny feels? I remember this from when I was little, and I was like, what? Like, no way. Like, how can anything taste, you know, like, how can you not want to eat? Food tastes so good, etc. But this is the look that we were all going for. And I look at that now and I just go, what were we thinking? Like, that to me, especially that I'm about to talk about, is just not healthy. Instead, and if you do look like that, that's okay, we can fix it. Okay? So, but we are actually embracing that strong feels better than skinny ever could. And if you have done weight-based training before, you will understand this. Now, I'm not going to go too much into this, what happens in perimenopause, because we have already had that discussion from Dr. Monika, but I just wanted to touch a little bit here. Obviously, we have estrogen and hormonal changes that does impact our bone density and also our muscle mass. I just wanted to show you this slide. What actually happens, this is a picture of a healthy bone, and this is a picture of an osteoporotic bone. Can everybody see that? Really, really important. I think when I saw this, I was like, oh my goodness. Now, what we do know is that if you do have osteoporosis and have a bone fracture, especially a hip fracture, that you are 3 times more likely to pass away in that following year if you have osteoporosis. Now, women over 45 who engage in resistant training, it's actually 2 to 3 times a week, reduce their overall bone fracture risk by 51% and their vertebral risk or the spinal risk by 44%. That's significant. So we are really obviously pushing for weight-based or strength-based training. Again, if we skip over, so osteoporosis, sarcopenia is basically when we are losing our muscle mass. Now, it can become highly problematic for a number of reasons, but one of the main reasons is obviously your metabolic health, but also just your overall balance and strength to be able to do your activities of daily living, which we do take for granted, I think. So when you see someone who has this muscle wastage and is a falls risk, it is really quite worrying. The other thing I wanted to talk about, when we lose our muscle mass, we do have a higher risk of gaining body fat. And as Mon said before, we sometimes, I don't know if growing up you've noticed we used to get a little bit of fat around the thighs. And as we're going into perimenopause, that is shifting towards that adipose or visceral fat. I just wanted to talk to you a little bit about that visceral fat side of things as well. So visceral fat is actually, can you see these okay? Yep. So visceral fat is actually the fat that wraps around your organs, particularly your liver and your intestines. So this fat is a little bit more dangerous. It is much more inflammatory, and it is actually what they like an endocrine organ. In fact, like it's releasing chemicals into the system that are not healthy for the system, which in turn disrupts your immune function. So we're in that inflammatory state, the immune system gets a little bit confused and it starts attacking or can attack tissue that is quite healthy, which then increases our risk of diabetes heart disease, cancer, and some, neurodegeneration. Oh, actually, I'm just going to go back a bit. In terms of what happens in perimenopause, these hormonal changes can affect in terms of our insulin resistance. And because we touched on that earlier, I'm not going to go too much into that, but just know that if you are struggling with insulin resistance, or if you are pre-diabetic, it's sometimes interchanged, exercise can actually really help with this. I'm going to go into that a little bit more in a minute, but one of the main reasons is that we are going to be building more muscle. So Dr. Gabrielle Lyon is the founder of the Institute for Muscle-Centric Medicine, and she does a lot of work around the importance of lean muscle mass. She actually states, based on her research, that the stronger you are and the more muscle mass you have, the greater your survivability against disease. Now, that's significant in itself. I'm just going to talk to you now a little bit about why strength training is non-negotiable. Okay, so if strength training scares you, that is understandable, because it's like throwing weights around and people look heavy and, like lifting heavy and all those sort of things. And it does look intimidating. When we talk about strength training, we're not talking about lifting a heavy squat or a deadlift. We're starting off small, usually starting off with body weight exercises only. And we will teach you how to breathe. The stuff that Heather explained to you before about that breathing technique, especially around the squat, the deadlifts, etc., is very, very important to protect that pelvic floor. So we see a lot of our clients who are lifting have actually got significant improvement in their pelvic floor function. And that's really exciting to see, as you said before. It's really exciting to see people get their life back and be able to function in a healthy way. So obviously, the reason why strength training is non-negotiable is because strength helps you have energy, obviously longevity and overall health. Now, it's building that lean muscle mass. Now, muscle, obviously, the more muscle we have, the higher metabolism. Because we are in our muscles, we have powerhouses, mitochondria that really burn through those glucose stores. So what we're trying to do here as we build that muscle mass, and obviously this is like talking in front of an endocrinologist. Mon, correct me here if you feel like I'm going way off track. But we have these things called, it's called glute floor translocation. Just checking. No. So in this, what actually happens when insulin is released, when you eat something, insulin is released into your body, and that brings those GLUT4 proteins, out into open up the cell to let those sugars in to be burnt. Now, insulin does that role really well, but the other thing that does that role is strength training. So what happens when we strength train is that those little GLUT4 that acts as that opening opens up those cells, and then the glucose can come into those cells to be burnt as energy, leaving less glucose to be running around in your system and also less insulin to be released. So it's actually super, super important to building that lean muscle. Also, if you think about it this way, which is kind of a way that I get most people into strength training, is that the more muscle you have, the higher metabolism, so that when you're sitting at rest, you're burning more calories. Yeah? So what do you reckon that means? We lose body fat. Okay, so we reduce our visceral fat, which therefore lowers inflammation. So you'll notice if you started to train, I've had quite a few of my clients say to me, oh, it's really funny, I've only lost like 5 or 6 kilos, but I don't have as much inflammation, and I feel like my joints are much more sort of like mobile and they move better. And I'm like, yeah, because we're lowering that inflammation. So our tissues are better. In terms of your bone density, as I mentioned earlier, it does improve your bone density, but therefore it's also improving your balance. We also want to look a little bit, I'm going to talk to you a little bit about brain health, and I do have a psychiatrist here as well. So, Padmini, at any point, feel free to jump in. But in terms of our brain health, we have neurogenesis and neuroplasticity. So neurogenesis is that, developing the new cells within the brain, and neuroplasticity is that adaptability of the brain. Now, the thing that is the most intriguing about this whole thing is this molecule called BDNF, which is a brain-derived neurotrophic factor. So what happens when we actually contract muscles? Your muscles release myokines, and those myokines stimulate this brain-derived neurotrophic factor. And the best way to kind of look at it is like a brain fertilizer. So it's fertilizing all of those neurological pathways, improving the neurotransmitters, things like GABA, norepinephrine, serotonin, dopamine, all the ones that make us feel really good and calm and relaxed or really switched on. That's actually helping just through weight-based training. So that is why we say exercise obviously releases endorphins and improves mood, but it is actually so much deeper than that. Now, when we were saying before about strength training and how, does anyone still feel like if you strength train, you get really big and bulky? Does anyone still feel like that? Because I've had lots of these conversations and I guess no one's going to admit to it, but I have seen people in this room who actually thought that if they lifted too heavy, they would get big and bulky, but that's actually the opposite. You guys laughing back there? I know it's you. No. So basically muscle doesn't weigh more than fat, but what it does do is it takes up way less space. Okay, so if you have a look, this is the same weight, say a kilo of body fat compared to a kilo of muscle. So what actually happens when we build muscle mass, we are building this strong, really nice, rich, metabolically healthy tissue. And the fat that is there is actually being used as energy to supply that tissue. So it's not like your fat is being replaced by muscle. It's the fact that you are burning more at a higher rate. Your metabolism is higher. And if you're eating in a slight calorie deficit, or even at the same as what you were before you started training, that body fat will actually start to be broken down and used as energy, which is why you see people that lift weights actually start to shrink. So shrink in terms of body fat, not shrink in terms of muscle mass, right? Does this make sense? Yes. Okay, so I just wanted to talk to you a little bit about the latest research. So Professor Belinda Beck, Dr. Belinda Beck, who's actually an acting professor up in the University of Brisbane, actually has done an amazing research project called the ONERO program. And in her program, she starts to talk about the importance of weight-based training for muscle mass, but bone density. What she talks about is, if everyone can see that quote, is that bone is a use it or lose it tissue. It needs mechanical stress, weights, to stay strong. Low intensity exercises such as walking, swimming, or Pilates are not sufficient to build or maintain bone density with those with low bone mass. So anyone with low bone mass, it's not necessarily talking about someone who's necessarily osteoporotic, but someone who is actually moving into that phase. And as you saw the statistics earlier, you know, those couple of years before menopause sets in and just after are the years that we are quite high risk. So there, if you're not strength training, it's probably a good time to start. And I know a really good gym where you can go. Okay. So in terms of movement, what we want to look at with movement is that we're wanting to aim, and okay, I've got another slide after this, but I don't want you to get overwhelmed with this. This is just what is optimum, but it doesn't mean that this is what you have to do to start out, but I'll come back to that in a minute. We are aiming for 10,000 steps a day, and that is to keep our metabolism active and healthy, but it's also for our circulation. So I'm not going to go too much into it, but I get really excited about like non-exercise activity thermogenesis. But if you've heard of NEAT, this is NEAT. So it's not just about walking, it's about vacuuming, it's about cleaning, it's about picking up after your kids. It's about literally just going for a 5-minute walk after dinner. That is going to be so much more beneficial than just sitting down and watching TV. And then we look at things like mobility and balance. So this is where we bring the Pilates side of things into it. Pilates, as Heather was talking about before, which is talking about that upper thoracic and even tightness around the rib cage, it can be quite problematic for a number of reasons, pain, but obviously also pelvic health issues. So we like to bring Pilates into it, where we use a lot of opening movements to open up that rib cage, a lot of breath work to try and help just calm that central nervous system, which we'll talk about in a minute. We also recommend strength training, or she recommends strength training 2 times a week. Optimum again is 3, but it's really important when you're strength training, it's not just throwing weights around. She talks about the importance of progressive overload, which is obviously how we write all of our programs, and periodization. So that's changing your programs up over time so that your body is continuing to adapt to that stimulus. And also cardio. So this is an interesting one. Cardio 1 to 2 times a week for 15 to 20 minutes for heart and metabolic health. Now there's a bit of a mixed like research out there at the moment. But the main thing that's coming out at the moment is that you only need 20 minutes, 15 to 20 minutes of what they call sprint training or high intensity interval training once a week. And then in the other 2 times a week, or one other time a week, they're suggesting that you would do a low intensity steady state training, which might just be sitting on a bike so that it's just a little bit tricky to talk, but you can sustain that for 15 to 20 minutes. So that's my favorite type of cardio. But either way, like if you love to smash yourself, by all means, go ahead. But I think it gets harder as you get older, don't you think? Anyway, but this is where I was talking about earlier. I just want you to think about it as starting small, because sometimes when we're starting out, there's this real fear of what it's going to be like to start out. But I guess working on the problem or taking the first step actually reduces the fear of the problem. So it's hard to fear a problem when you're making progress on it, even if progress is imperfect and slow, because action relieves anxiety. And I think one of the things about MaxFit is that we really want to encourage just those small efforts, and we want to really work with the body and not against it. So this is all part of our approach. So if you are feeling a little bit nervous about starting out, and even if you don't feel like you can come to a gym, come and have a chat to us after, or even just pop some questions on the chat, and we can answer those about some options that you might be able to take on board. So nutrition for hormones and strength. Now, I'm not going to spend too long on this. I probably will now I've said that, but what I wanted to talk to you about in particular is protein. I'm just going to go to my notes because there is a study that I wanted to refer to, and it's by Professor Bill Campbell. So Professor Campbell basically does a lot of work around muscle mass, and he does a study, and this particular study was in the University of South Florida, where he had two groups, a control group and obviously the subject group. So in his group, he started both groups off on 1,500 calories, and each group had to continue to do progressive overload training 2 to 3 times a week, and then they had to eat the same amount of calories except for the study group. He added an extra 400 calories protein only in that group, and guess what happened? Anyone? They lost weight. So the girls, there were only girls, by the way. I should have said that at the beginning, because it's relevant to us, so it's girls. So these women who took part in the study and ate the extra protein, they actually lost 2% of body fat compared to the non-study group, which was only 0.8% body fat. And they gained 2 kilograms of muscle mass over an 8-week period. So they say in this particular study, obviously the conclusions are the fact that if we eat more protein, we're building more muscle mass and we're losing weight. So this is why anyone seeing me for nutrition coaching, I'm always on about, please increase your protein, however that might look, because not only does it help you in terms of building your muscle mass and your recovery, it's going to help your cognition, but it's actually also going to help in terms of your recovery and making you feel like you're able to continue about the day with a lot more energy, making you feel fuller, so you're not going to start reaching for those foods that are really high in calories, empty calories. So in terms of your protein, I don't know if you can see that well enough, but those are things like, you know, your meats, your legumes, obviously they have a bit of carbohydrate in it as well, cottage cheese, everyone loves cottage cheese. But yeah, so protein-rich foods obviously need to be, we would hope to be included at most meals, and you're looking at around 20 to 30 grams of protein per meal. So 20 to 30 grams of protein is about 100 grams of chicken or beef, and it's kind of like about that amount, like on the palm of your hand. So it's actually not crazy amounts. The other option as well, you know those protein bars that you all had when you came in? They've got about 20 grams in them, and a protein shake has about 30. So the sachets of protein that you have there is 30. We just make those up using ice. You can use normal water or coconut water, almond milk, whatever it is. But that'll give you about 30 grams of protein. For someone who has a lean muscle mass, well, I want to say an ideal muscle mass or fat-free mass is what we calculated on. So we might say someone who's about 80 kilos might be looking at around 150 to 160 grams of protein per day. Okay, so if you know that you do have quite a lot of body fat to lose, we're not going to necessarily calculate it on that weight, but more on what that lean mass might be. If you do have any questions about any of this, please make sure you put it through, because this stuff is can be a bit complicated. Forgot to mention, these are all called macros, okay? Macronutrients, okay? So I'm sorry I didn't bring that up earlier. So not this one. This one's not. Well, technically alcohol is a macronutrient, but we'll go into that later. Healthy fats. So there are a lot of unhealthy fats, but the healthy fats that I want to kind of include today are things like eggs or egg yolks, like salmon, olives, nuts, avocados, olive oil, you know, all of those sort of things. Really nice healthy fats, not the fats that you find in high processed foods. These fats are really important for your brain health. not only just for your brain health, but your hormonal function as well. Because don't forget, your brain is mostly fat. So it's really important to be eating those healthy fats. And also fats do help you stay full. I'm going to move on to carbohydrate. Carbohydrate, I feel, gets a really hard time. People tend to demonize carbohydrate, and I don't think that's fair because carbohydrates are really valuable, but it is the type of carbohydrate that we eat. So we're looking at carbohydrates that are really high in fiber. So those are the more complex carbohydrates, the whole grain carbohydrates, or vegetables like sweet potato. Potato's fine, by the way, everyone. For some reason, people have a problem with potato. It's actually really good, especially if it's been heated and then reheated, because it has resistant starch, but that's a whole other story. But all of these are really healthy and helpful, because we are also talking about microbiome. Have you heard about microbiome before? So basically with our gut microbiome, it's like trillions of little microorganisms that are in the gut or like in the intestines. And those microorganisms can consist of bacteria and virus and fungi and all of those different things, those little microbes, and they live inside our body to be able to help us. So if your microbiome is healthy, you will notice that you have much better health, your immune system is stronger, you get less gut pain, you probably got better sleep, and you're probably less irritable because of the gut-brain axis. So that gut-brain axis actually is quite strong. So you'll find that most of the serotonin, or that hormone that makes you feel nice and relaxed and happy, is actually produced within the gut. When our microbiome is out of balance, that is when we get this dysbiosis or this unbalanced gut, and then you can get things that perhaps like gut pain, irritable bowel. I don't know if anyone's had that. Different autoimmune conditions can be triggered from it, and even some mental health issues. So Professor Timothy Spector, who heads up the Zoe Initiative, if anyone's heard of him, if not, he's got a really great book out that you can have a look at, or even just following him on Instagram would probably be a good start. He actually talks about it's really important to eat 30 plants per week, but coffee is included in that, okay? So anything plant-based, so that can be anything from coffee, chocolate, because it's plant-based, through to like any type of carbohydrate that you're thinking about, chia seeds, nuts, all of those sort of anything plant-based. And it's actually funny because when I looked at it, when I first read this, I was like, I've got to find out how much I'm eating. I was on like 26. So it's actually not as hard as what you would think. But you know what, even if you're just starting off with 10, that's better than 1, right? Not that anyone would be eating 1, but now, so the last thing I wanted to mention as well is that processed foods are actually really damaging for your health. And even though it might say it's high in protein or it's high in fiber, it doesn't mean it's not processed. So we're trying to look at foods that are close to the source as possible. So I would be suggesting just trying to limit foods that have, like, if you look at the nutritional information, just like everything that's like, if there's like a list that long, it's probably best not to eat it. So the less ingredients, the better, and the less numbers, the better, just as like a rule of thumb. Alcohol. Now, so alcohol is an interesting one because the World Health Organization has just released a statement to say that no alcohol like is healthy, like you shouldn't be having any alcohol. But let's be honest, like that's not necessarily realistic, because you have to look at the risk of harm compared to the benefits that you're actually going to have from anything that you take. So for some people, sitting down, relaxing on the veranda, you know, with a friend or a partner and having a glass of wine or a vodka lime and soda, whatever, not that that's my choice or anything, margaritas, whatever it might be, that benefit that you will get from that relaxation and that time may outweigh the risk that is associated with the alcohol itself. They do recommend that 15 grams of alcohol or pure ethanol, so the alcoholic part, which is usually 1 standard drink per day, is supposed to be least harmful. So again, spacing that out, if you're going to have more hourly with a glass of water in between, is supposed to be more helpful. This isn't just about, you know, calories. This is actually about your metabolic health and the way that your body is processing hormones during perimenopause. So you'll often find, as Monika mentioned before, when you are in perimenopause, those symptoms can be exacerbated by things like alcohol or caffeine, etc. Coffee is always fine. Sorry. But honestly, it is. No, okay, coffee, we'll come back to coffee. Just bear in mind that if your system is upregulated with cortisol anyway, and you're adding caffeine to that as a stimulant, you're going to feel a bit more stressy. So it's probably not overly helpful to consume too many coffees in a day. And sometimes those hormones are fluctuating. So just keep an eye on that. And if you're feeling a bit overwhelmed, maybe just a decaf or something. I'm not really sure. Hot chocolate, protein hot chocolate. So the supplements to consider, we really recommend protein, collagen, and creatine. Okay, so creatine is a new flashy, let's take it supplement. It's great. It honestly is. It's going to help with performance. It's going to help with recovery. It's probably also going to help with gut health and cognition. But if you're going to start with a new supplement, I'd be starting with protein. So if you want to take something new, I'd be looking at protein before anything else because it is a foundational supplement. And obviously, calcium and vitamin D is really good for bone health. Magnesium is great for stress and sleep, especially if taken before bed. And also you can look at a probiotic because, you know, that microbiome can be supported by probiotics as well. So those are all options for you just to consider if you are wanting to take a supplement. Now, I'm just going to talk to you a little bit about mindfulness. Okay, so don't get switched off here because it's not like mindfulness. It's actually talking about how to best manage the stress that comes along with perimenopause. I'm assuming that some of you might have felt like little elements of rage or tension or biting your husband's head off or throwing all your kids' toys out because they're in the way. I don't know anyone that's done that. But anyway, mindfulness. So what actually happens with our hormonal shifts is that estrogen is quite protective for the brain. And like I said before, it helps, you know, just with the neurotransmitters that are in your brain, etc., can be affected when those estrogen levels, progesterone, etc., drop or change. So what ends up happening is that we get an increase in anxiety. So anxiety can feel like kind of increased heart rate, dryness of mouth, a little bit nervous, tension, maybe a bit sick to the stomach, might change your bowel habits, etc. So it's basically when your body is perceiving a threat. So it goes into that fight-flight mode. Then we have the stress response is this fight-flight mode. It goes to the hypothalamus. It's like something's wrong. We need to do something about it. So it stimulates that sympathetic pathway. When I say sympathetic, it's just that fight-flight response. And then the body releases adrenaline and cortisol. If this happens for a long enough period of time, it can actually become quite damaging to the body because cortisol actually increases your desire to want to eat more, and it stimulates that ghrelin response. So you're actually getting hungry, and you're probably getting hungry for foods that aren't particularly helpful. Mindfulness then interrupts that loop. So this is what we want to talk about just for a bit, calming the nervous system. So what is mindfulness? Mindfulness is not about emptying the mind like you might think and trying to think of nothing, because I could never do that. It's about anchoring in the now and letting the body exit that stress response and allowing that recovery and hormonal balance. So when we talk about mindfulness, there are a couple of ways to help you with that. First of all, you kind of want to think about your brain is in this loop of trying to fix a problem that doesn't exist. And it might attach to anything. But maybe if everyone can just think about the last thing that they were overly stressed about or ruminating about. Everyone just think about it. So what your brain is trying to do is solve that problem that doesn't necessarily exist. So it's throwing up all these different ideas constantly to try and get you to focus and fix this problem. What we want to try and do is calm that nervous system down and move you out of fight and flight. So we want to try and engage the rational brain, because when you are really, really stressed, it's shutting off the frontal lobes, and they're responsible for executive functioning and planning and processing and all those sort of things. So instead of being like rational, when you're in that anxious fight flight, you become irrational. So mindfulness takes practice. So what we want to try and do is move ourselves into a calmer state. So I'm just going to get you all to take a nice deep breath. I reckon you can do better than that. What we're actually going to do is, the latest research is coming out. I don't know how many of you have seen this research, but it's talking about the sleep breath. So when we take a nice deep breath in, have you noticed that sometimes when someone's asleep, they'll do this, they'll go like that? It's their body's way of trying to calm down and stay in that sleep state. So we want to take that extra little breath at the end. All right, so take a nice deep breath. And then again. And can you feel those lungs expanding? And then slowly just releasing that breath. Because what we're trying to do is we're trying to increase that lung capacity. So we're trying to increase that surface area to volume ratio. So there's more oxygen actually going to the body and therefore signaling that we're okay. The other thing you can do is opening up. I don't know if this is always practical when you're in a bit of a panic, but just opening up into the extension, okay? So when you open into extension, you're actually signaling to the body that you're safe. Because when we're stressed, we tend to go into that protective mode. But if you are opening up, you're actually telling your body we're safe. So that's another option as well. So what I want you to do is think about what is going on around you, noticing the thoughts that might be going on and actually stopping them for what they are. So for me, I go, oh, hang on a minute, you're anxious, your adrenaline's running, your frontal lobes are off, just settle down. It's not even real, and get on with what you're doing at the time. So sometimes it might be, oh my gosh, you're worrying about trying to pick up, this is stupid, but this is what I do. You're worrying about trying to pick up one kid from here, the other kid from there, getting that kid there. And then you just sort of overthink, what happens if this happens and I can't get them? And what if that parent thinks that I'm dodgy because I'm late? Like all those stupid things. It's just a matter of owning it and going, okay, I know what's going on. This isn't actually helpful. I'm naming it that I'm worrying. So here, thinking, I'm worrying, taking that deep breath and bringing your attention back to that present moment of what you're actually doing. What will happen is your brain will automatically go back to wanting to think about it. So then you're just gently bringing your attention back to what you're doing at the time. So this takes practice and repetition, because you want it to become a new default pathway. Because what's happening in the brain at the time is that you're so used to going over this rumination, we're trying to break that rumination and come back to this more helpful process. Has anyone tried this stuff before? Yeah. Did it work or did you give up? Gave up? What? No. Let me tell you, this work will change your life, but you have to be prepared to practice this and repeat it. Because think about it this way, you've got a little path and you're walking down that path time and time again of rumination and worry. Instead, you're trying to create a new path. So we're switching the brain onto this new path, and to forge that new path, you've got to use it. So
What can you see? Can you hear? How do you feel? Those sort of things. Of course, strength training is a massive help because of what we mentioned earlier with those myokines and the brain-derived neurotrophic factor. Really, really helpful. So if you've noticed, I often get this, oh, I don't feel like training, I'm so tired, I'm so exhausted, I'm so stressed. People will train, and then after that, you've got this amazing surge of clarity. And obviously during it, it's practice. It's practicing showing up time and time again, and getting that release. And then you'll get addicted and then you'll want to train again. And then filling your cup. So that's going to look different for everybody. Full disclosure, filling my cup at the moment does look like Netflix and chill. But switching off to be able to just allow that brain to decompose. Some of you, it might be a book. The other one I love is catching up with friends. Things like that, just whatever it might be. It might even be hanging out with children. But I guess the main that to do is just to help you guys get to a point where you feel strong, nourished, and calm. I'm not doing so well in the calm part, but I'm getting there, and it is through practice, and it is through, I guess, having people around you that can support you with the, I guess, the goals that you've got, the things that you're wanting to put into place in your life that you think are going to actually benefit you, having people in your corner to support you with that. And I think, we have got a great community at MaxFit that does do that. So I guess just to sum up, we really want to look at this as being about energy and longevity, and the best way to do that is to be incorporating, being strong, being fit, keeping that movement going, making sure your nutrition is dialed in. It doesn't have to be perfect. It just has to be a small little change to start, and even just practicing things like mindfulness. So that's it from me. Just going to hand over to V.
Can I just confirm that everyone has received a lucky dog ticket? Yes. You want one? Does anyone need one? Okay. Okay, so before we ask, before we move on to your question, so the lucky door prize. So as I mentioned earlier, the winner received a 10 class pack at MaxFit, which can be used for any of our classes. So we've got strength and conditioning, MaxFit modified, Pilates, stretch and tone. So I wouldn't even know how to even draw it. Now, Lara, would you like to?
Oh, I'd love to.
Do you know what we won the other night at the Glen Haven? We won $250 worth of lollies. New diabetes pack. Okay. A11. Wow. A11. Yay! Here we go. I'll bring it to you. Oh, congratulations. I'll make sure Grace is not in the gym when you're training. Grace. Grace is obsessed with Mrs. Barton. Okay. So I'll now hand you over to Marnie, who will be going through the questions that you have submitted through the QR code. And as Lara mentioned again, feel free to ask any questions. We're just going to come and sit up here. So and you guys can ask questions. Okay.
So I have a few things. If anyone's got any, I know it's anyone.
Just talking to that and then give it to someone. It's for the Zoom.
Yes.
I'm trying to minimize. Hoping everyone's.
Oh, very awkward, isn't it? No. So I do have a few questions. One is, and it would probably be good to get an answer from all three of you separately for this one. If there is one lifestyle change that women who are middle-aged or older should be making, just one, what is it?
First, lucky me. I feel like I'm supposed to say strength training.
Yes.
Say, I don't know, I think the bladder urgency is the one that gets the most for me. Women who put up with bladder urgency for so long, to the point where their social situations are like, where is the bathroom? I cannot go to this new place. They're fluid restricting before they go driving in the car, on holidays, or they don't want to go flying on planes because of that. It just seems to cause such a huge social impact. So to me, if they have bladder urgency, doing something about it, not just putting up with it or having their family give them a lot to eat about it, that's
I think I would have to say, I think strength training, in my opinion, is quite important because I see a lot of women around perimenopause with the osteopenia and osteoporosis. And I obviously didn't spend as much time on it as Lara today, but I do think it's really important to help with that improvement of the insulin sensitivity, because as you're more active, that at the muscle tissue improves your sensitivity, and that helps with that visceral adiposity. So I think, and it strengthens your bones. So that would be my pick. Strength training, super important, and at least twice a week. Yeah. And
I feel like Lara doesn't even need to answer.
That's it's exactly that. It's that insulin sensitivity, but it is also obviously those protective factors. But protein, I'm going to say protein because strength training has been mentioned. Protein is really important, as I mentioned. So I think that would be one of the main things. And also just trying to remain calm, because if our stress levels are so high, it's really hard. It's really hard to remain calm. And I get it because life is frantic, but those deep breaths just intermittently can really, really help. So just a few deep breaths will go a long way.
Okay. Next question, and I guess there's so much information out there in the world, and it is really hard to know if you're a woman who suddenly is getting those perimenopausal symptoms, and probably in the 20% that you talked about, Monika, where they're really affecting your life. A lot of GPs are unfortunately quite useless for women when they go and talk to them. And you know, you can have to go down a path of GP shopping. I know I did. And I'm still not 100% happy with the purchase that I've made. Still continuing to shop. Can you recommend any podcasts or books or anywhere people can go to start educating themselves and getting accurate information instead of the social media influencer?
I would go to the Australian Menopause Society website. They have a lot of really good resources there in terms of just the symptoms, you know, what symptoms you may have, whether that fits with that. So I think that's a really good evidence-based resource to look at. And as I mentioned in my talks, they also have a list of any GPs that have an interest in menopause. And of course, us as endocrinologists deal with that realm as well. But I think it's important because there's, I guess, a lot of information out there, and you want to be getting your information from a respected resource that is, you know, getting misinformation about if there can be a lot of misinformation out there about what is perimenopause and how to best manage it. Yes. And I think if you are not feeling like you're getting for a GP, please go and seek another opinion. I think it's important to feel that you're in a safe zone and you're getting listened to and being heard, and that they're supporting you in your journey, because I mean, many of us are in this stage, and I think you need someone who's on this journey and path with you. Can I just add really quickly? No. I just it's not
See us after. We do have a great list of doctors that you can see, so GPs, but also endocrinologists that you can see. So come and have a chat to us and we can put you onto those people.
Okay.
I'm trying to think off the top of my head. There's a couple of different podcasts that the main one that I quite like is an ABC podcast called Ladies We Need to Talk. And they often interview gynecologists, they interview doctors and health professionals on that. And I'm sure that there's one around perimenopause and menopause that is really quite informative and quite inclusive in the way that they describe it and symptoms. And so I feel like the other one is the Pelvic Health Podcast, which is often like where there's health professionals being interviewed. I feel like that's often going to be a more informative approach to be taking. And they can sometimes be helpful tools that provide different options of information as well.
What I was just going to say, what we can do as well is maybe pop a list up, and V's got everybody's email, so we can pop a list up of different podcasts and counts to follow, because obviously there's Dr. Louise Newsom, Dr. Mary Haber, you've also got Dr. Rhonda Wright and Dr. Gabrielle Lyon. So there's quite a lot of them that you can follow. So I'll pop up like a list, and then there'll be a link to that.
I do about 4 questions come through about intermittent fasting, which is an interesting topic.
I can answer this.
One of them is intermittent fasting has interfered. Intermittent fasting delaying the first meal of the day has interfered with my bowel habits. Any advice? I'm just going to group them all together so that we can cover intermittent fasting quickly. Sorry, I've just got them coming through from a few different people. So, just got to find whether I'm just going to ignore it anyway. But it's just, there's been a few questions asking, is intermittent fasting useful for women in menopause and perimenopause?
Okay, so intermittent fasting, yeah, so in terms of like autophagy, the body and its way that it replaces its cells is naturally geared for that. And in terms of like a fasting window, it is sufficient if you were to finish eating at 9 p.m. and then start eating again at 7 a.m., sorry. That is a sufficient time for the body to be able to have time to do that. What they have noticed, and I've read a few articles on this recently, because intermittent fasting is huge. And it's often studied within male populations. So what they have discovered is that when you wake in the morning, your cortisol levels are higher. And so you become quite catabolic, or you're eating into muscle for energy. So they have shown some of these studies that it's important to be able to eat something that has a relative amount of protein and carbohydrate and a small amount of fat to be able to bring that down a bit and get you out of that catabolic state. So any of these studies, if you're interested, just let me know and I can forward you on these studies so that you can have a look for it at it yourself, because it's important that you're informed. So in terms of intermittent fasting for women in perimenopause, I would say that the research that's coming out is not ideal, and it does also affect metabolism. If you if you're finding, especially before working out, that you can't eat before working out, it's probably better to eat something that's really quite high in protein the night before with a bit of carbohydrate to help sustain you before you train. Because I know a lot of people train early and they don't want to be eating before they train. The main reason that intermittent fasting works is because you're reducing the time that you're able to consume calories. That's all, the only reason that they're finding that it's working. Is because if you're eating between 12 and 6, you've got 6 hours to consume a certain amount of calories. Now, if you're trying to build muscle, that's not helpful at all, because you want to be opening up those windows to be dropping 20 to 30 grams of protein every 3 to 4 hours. You can't do that if you're intermittent fasting. And if you've noticed that your bowel habits are changing, it's probably for a good reason. And it's because you're not giving your body what it needs or the amount that it needs in the time that it requires it. So if there's any more questions around that, please send it through, but I'm just going to pass over to you guys.
I mean, I would agree with Lara. I think there is different approaches to the dietary point of view. I think if you are someone that normally doesn't eat breakfast, I would agree with Lara having protein the night before. Intermittent fasting from an endocrinology point of view is not superior to the other diets. In our diabetic populations, we really focus on a low glycemic index and a higher protein diet, and intermittent fasting does not add any more to improving the glycemic profile and insulin sensitivity. Okay.
You don't want to talk about constipation?
Just a few more questions. There have been quite a few come through about hormone therapy, and I know that this is a little bit tricky for you to answer because it has to be a one-on-one conversation in a medical setting for you to give advice. But in particular around the big breast cancer, which is what everybody has been told hormone therapy causes from what my reading is and from the information presented. It's a lot of risk unless you have certain health issues. But someone's asked, is it beneficial to take hormone therapy with any other cancers, or also it would be good to know if it really does help in other areas like heart disease and osteoporosis?
So the breast cancer risk came about from the Women's Health Initiative study that was published in the 1990s. And as a result of those results, there was really a shift towards not using hormone replacement therapy until the more recent studies and data came out. And what they found in those earlier studies was that they were using more synthetic progestogens and also synthetic estrogens. And they were also looking at a lot of older women. And so the newer preparations, we have the transdermal preparations, and the micronized progesterone prometrium are body identical, so much safer than the previous preparation. So the breast cancer risk is much lower than was on the earlier preparations. As I mentioned, depends on the duration of treatment you're on as well. I think there's a place for menopausal hormone therapy in other diseases. So I see women with osteoporosis and osteopenia who may not have any hormonal symptoms. They may not have hot flushes or a night sweats or the typical symptoms we discussed, but they're osteoporotic already, or osteopenic with a fracture. And they're at that transitional phase where we know they're going to be losing the greatest amount of bone loss. And so my approach is strength training, absolutely, as we talked about, number one. And then perhaps menopausal hormone therapy to really stop that, dampen that bone loss around that critical time for them. And it's evidence-based, and it is now one of the recommendations for women around the menopausal stage to consider menopausal hormone therapy as well, for women at high risk of osteoporosis. And then the other question was, is there a role for any other cancers? Not to my knowledge, but it has cardiovascular protection. We wouldn't be using it for that indication though at this point in time. I wouldn't be prescribing it to protect your coronary arteries. It would be as an added on benefit to treat bone health or menopause.
In terms of that research, is there any research that looks at topical or local estrogen as opposed to systemic estrogen? Because I would say that a lot of our clients would be using topical estrogen, which from my understanding comes with an even lower risk in comparison to systemic.
So if you are someone who's had a hysterectomy and is just on estrogen alone and transdermal estradiol or gels, the risk of the breast cancer, as I showed, is quite low. 1 extra case per 200 cases, which is quite low. So it's not considered to significantly increase your risk. It's just non-estrogen alone.
Yes, and if that's vaginally applied estrogen, do you know much around that?
To my knowledge, there is no increased risk with that, and that is very much just it's only locally absorbed, so you don't get the systemic effects from transvaginal preparations. So that
And I'm just reading the room and people seem to be getting restless, and I'm guessing probably want to go home and get ready for another delightful day tomorrow. So just one of the final questions come through, that is your advice on strength training during days when you are experiencing a heavy menstrual cycle.
Yeah, so I would suggest, so when you remember that when Monika put up that slide about the actual cycle of the phases in terms of what I would be recommending is if you do track your cycle, when you are on day sort of 27, we're looking at a 28-day cycle, just for this particular, just highlighting this because everyone's cycle changes. But if you know that your cycle is around sort of 28 to 30 days, around day sort of 27, 28, you want to start backing off your strength training. You want to start to lighten up a little bit and have a bit of a deload. So if you want to do that, you can increase your rep range and back off on the weights. That's probably a good time to do it. In terms of when you're ovulating, that's also a time when you're at higher risk of injury. So it's probably not a time when you're looking for a PB. So that really cancels out a lot, doesn't it, in terms of strength training? But I guess what I'm saying is I tend to just track my cycle so I know where I'm at. And if I'm wanting to do a really heavy lift around my ovulation, I'm just going to make sure that it's a closed chain or a lift where my feet are stable on the floor. And I want to make sure that I'm breathing really well and concentrating during that lift. And then if it's just prior to your cycle, you're probably looking at the first 3 days of your cycle, you're also going to be backing off on that. So you've got about 5 days there where you probably want to just back off on the weights a little. And then during ovulation, you're probably not going to be wanting to throw yourself around and doing lots of plyometrics because you are at higher risk of injury in terms of, especially with those connective tissue injuries. Does that answer that?
Well, I would argue as well, like, let symptoms be your guide. I wouldn't say that just because you're ovulating or supposed to be ovulating at a certain day that it's a definite risk factor for you. I think what a lot of the research, interestingly enough, is looking at is that there's actually quite a variation in the hormonal profile, that just because day 14 is the standard day of ovulation doesn't necessarily mean that every woman ovulates at day 14. Let symptoms be your guide. If you're feeling heavy on Monday, is that the day to be lifting your heavy weights and make you more symptomatic? Probably not. But if you're feeling okay and the symptoms are okay with that, then we would argue like maybe your hormonal profile is different and there's not necessarily a cookie cutter mold for every individual, but letting symptoms and modifying in response to symptoms, not pushing through symptoms, I would argue, particularly on that first day of your period. If you're heavily bleeding and you're feeling uncomfortable, that's not a day that you need to be lifting heavy within that. Modify and adjust and adapt for that. But if you're feeling okay, then potentially that's a time that maybe you continue as before.
And let's be honest, if you're in perimenopause, you don't have regular fluids anyway. So you gotta fix it. So they go.
All right.
Yes.
Okay, so before we close, I want to thank everyone tonight. So I hope we're all leaving here with some new insights, encouragement, and sense of community. And of course, a very special thank you to our amazing guest speakers. So we've got Lara. So please help yourselves to any true protein bars, stress balls, you may need it. And if you want to ask any questions, please reach out to minutes. Yes. Thank you again and safe travels home. Yeah. It's very Take care. They can hear us.
Okay, thanks everyone. Oh, oopsie, wait, goodbye. Okay, recording. Stop recording. I'll just